Mr. Chairman, ladies and gentlemen, thank you for the privilege of being able to talk at the International Melanoma Conference and the Society Congress of Melanoma in Brisbane in October. Incidentally, I should say of myself, I'm one of the old school. I've been presenting at melanomas, and I remember the years gone by in Venice doing a presentation on desmoplastic melanoma, which was one of the first publications around before things got into prominence. I have since that time developed what we call a keystone Ireland flap reconstruction. Why the word keystone? Keystone refers to the arc nature of the design. It's an Ireland flap, it's perforator based, it's fascial lined, and is designed within the dermatomes. And that over the body has been my reconstructive success tool. The second point I must make is that my colleagues at Peter MacCallum Cancer Institute, mainly Michael Henderson, and David Speakman, and also young David Gorky, and Sarah Leone and Imelda Motoroko, which have given me access to cases which otherwise, if I hadn't had the stimulus and their referral requests, this design would not have got off the ground. In summary then, can I just point you to the number 2 slide? It's an arc. It's called a keystone because of the nature of the archaeological, at least the architectural design of the shape. It's a Moorish principle in which the keystone of the early Moors came across, and that's why the Colosseum today, if we look at the images, has up to 3 stories because of the arc nature of the arches between them. The KPIF, as I call it, the Keystone Perforator Ireland Flap, was designed within dermatomal precincts, therefore has a neurological base. And if there is fascial lining there, that ensures the vascular integrity, because you cannot have a nerve supply without a blood supply, whereas a lot of perforator flaps have a blood supply without a nerve supply. And we also look at the story of the old propeller flap, which sometimes they quote a 46% complication rate. As a result of this islanding, we have the red dot sign, which I'll point to there, which indicates that the flap, after 15 or so minutes, bleeds more on the flap side than the receiving side. And this vascular flare is consistent with a sympathectomy effect, we think, which has also allowed us to also assume, we do not know, assume that lymphatic drainage also is opened up as a result of this. But the most staggering thing about the keystone concept is it is pain-free. We've all had a surgical wound, which is anaesthetic on either side initially, and before we make it into a rectangle or something like it, the area, before it reinnervates in 2 or 3 months, it is pain-free. Here's some cases from head to foot showing these principles. The video format will illustrate the method, and the biggest difficulty I had in popularizing the use of this technique is people think they know the way that I've done it. I've done now over 3,000 cases over those 20 years from 1995 when I began off the ground to 2015 when I retired from clinical practice. But these are the aspects which you can think at a clinical point where if it is, I've explained also the pain-free factors, aesthetically it matches, complications are rare, and the only complications are those in which tension, which we do close under tension, sometimes they rupture or break down because of inappropriate wound removal by people in an outside clinic. Economically, in terms of time, it's hours rather than it can be a shorter time frame rather than a long time frame, and it's simple to form by many specialists. And Michael Henderson even said to me recently, I need the defect, I need the closure, and I put in a keystone. I refer you now to the publication that came out of the Mayo Clinic last year. Sancia is the guy who is popularised the importance and geographically of the nature of perforator supply in Ireland flap reconstructions. He invited me to become co-author, and incidentally, not to be boastful, but in the reference side of the publication, 14 of my keystone papers are there. So if you want a summary of them, go to that particular paper. I put a bit of history in next. One may not know, and I didn't know till recently, till this image came through from Paris, from my bookseller over there on the left bank. There is a photograph of Sir Henry Head's publication of 1900 when he determined the dermatomes of the body from herpes zoster. And that was a little doll image that they had, and that's available for purchase last year. Of course, the modern Grays image is just a repetition of that. The next point of interest I'll dive into now is why is it an arc keystone? Initially, I called it an arc flap, but I have to say publicly, my colleague in Melbourne, Alan Bridle, corrected me one day. He said, "Felix, why call it an arch or an arc flap? Why not call it a keystone?" It's been a win word, it's been simple, most can understand it. And as a consequence of that, when you look at it, when Joseph Andra, another of my colleague, associates in Melbourne, asked me, "Felix, how does it work?" I said, "I have no idea." But I drew a line between the extremes once, and I said, "Shucks, we've got two VY flaps," which, as we know, Diefenbach introduced into surgical reconstruction in the 1850s in Berlin. So you can have a keystone arc, but if the surgical defect governs it, it's not always fitted by an arc, it's governed by a square or a rhomboid, and this recent variation, we can make it into an Amiga variant, which is a U-shape turned as long as a third's attached. That third attachment is the most important aspect in reconstruction. If you've got attachment of a certain dimension, it's a third wide, it will live without Doppler localization of perforators. Next slide is another case.